So, my dear colleagues, I have a task to present you a pathophysiology of abdominal pain. And I think that the main task of my speech would be what have you know about the causes of abdominal pain and what to do during consultation of patients at the drugstore, and especially what not to do to avoid complications. And so this slide is presenting mechanism from mechanism to management, and with a very not simple definition of abdominal pain as one of the most common symptoms. Patients seeking help, especially and directly from pharmacists. And in this definition of abdominal pain, we have some problem, because when we are speaking about just abdominal pain with a high intensity, it is understandable for patients and for people providing medical service and counseling. And when we are speaking about another types of abdominal pain, for example, very low, as a sensation of discomfort, it is very hard to explain when I'm a patient, what do I feel? As soon as, for me as a doctor, and for example, if you are working at pharmacy, what does patient wants to tell about what symptom we have to think. And so this slide shows our key pillars of competent pharmaceutical counseling, with understanding the cause of mechanisms of pain, assessing its duration, what is it very important, determining the nature and character of pain, and in identifying red flags or alarm symptoms, which we'll be discussing with all our colleagues today. Yeah, I think. And that is why this clear understanding of the pathophysiology physiology and different classification we will present it you today to understand the necessity to prevent an inappropriate self-medication or inappropriate recommendation to our patients. So this knowledge of pathophysiology and mechanisms of abdominal pain is a key to high-quality counseling patients, especially in pharmacies. So one of classification which dividing abdominal pain by duration, you see acute and chronic as one of most broadly presented, with a time of onset. Acute is an abdominal pain by the different classification and definition, not more than 24 hours, but mostly not more than 7 days, which is presented in this slide. And chronic one is abdominal pain with a duration more than 3 months. And there is a gray zone between 1 to 3 months between all these two main types of pain by duration. And when we are speaking and understanding the acute pain, it's characterized by sudden, sharp intensivity, and with increasing maybe rapidly. And typical causes of this pain are situation connecting with abdominal catastrophes. You have to know that there are acute appendicitis, pancreatitis, and all another itis from different organs, including abdominal, intestinal obstruction, and acute failure of vessels. And a chronic one characterized more mild intensity of pain, maybe dull, aching. Very oftenly we will speak together about cramping or spastic cases of pain, with the typical cases connecting with mostly gut-brain interaction disorders, and by old classification is functional abdominal disorders. And typical cases are irritable bowel syndrome, functional abdominal cramping pain, functional dyspepsia, and another. And so there are mapping of and geography of pain, which can give you more understanding of the origin of pain. But we have now, you have to understand that not every time the location pointing by our patient is connecting with the real origin with the pain because of the types of innervation. Another classification is by etiology or by cause and by mechanism of pain generation. So if we try to ask two questions, is there structural damage? There are two answers, yes or no. If yes, it's connecting mostly with organic pain, and no, it is connecting with a functional pain. And another one, which structure generates the point signal, the pain signal. And so now we will see another one, classification dividing pain by pathophysiology on somatic or parietal visceral pain and referred pain. The question is the structural damage. I told that organic pain connecting with the presence of specific anatomical or physiological or even metabolic cases. And more commonly, the cause of acute abdominal pain. And functional one, when organic cases are excluded or absent, and there is a type of visceral hypersensitivity or smooth muscle spasm connecting with altered motility, disrupted gut-brain interaction, and perpetuating to vicious cycle of pain generation and chronization of complaints. And this slide presenting us these three types of pain signal, which are going from somatic or parietal peritoneum, visceral, which gives nociceptive signals arise mostly from hollow organs and the capsules of parenchymal organs, and referred pain when signal arising from one organ and perceived in another. That is why not every time when patient shows you a location of pain, it will be give an answer about origin or anatomical structure responsible for this signal. And this slide gives us deeper understanding presentation and formation of somatic pain or visceral pain. All is starting from activation of nociceptors from gastrointestinal organs with activation of nervous system and individualized pain perception from patient to patient. Somatic pain connecting with nerve fibers oriented with parietal pain, and in this case pain is a very important signal of protective response and gives us information about acute abdominal catastrophe and surgical pathology. And visceral type of pain also connecting with activation in nerve fibers, giving signals about the visceral or mostly chronic pain, and connecting with recurring episodes of pain, which is levels or increasing during exacerbation with formation of chronic pain memory. And so another slide demonstrates the features of parietal pain with a clinical signs mostly well located when patient can show by finger or by hand where is pain located. Typical causes I already presented you before, and important for the pharmacist as a tactic is to understand that this is mostly signals about organic or surgical pathology when symptomatic treatment in pharmacy is unacceptable, with an urgently needed to refer to physician or emergency case. And here are the list of red flag symptoms needed urgent referral to a physician for diagnosis or maybe treatment at all. And features of visceral pain presented on this slide with clinical signs of dull, mostly diffuse, very oftenly cramping and colicky type with intensivity that can changes during all the disease. And typical cases presented here are connecting mostly with gut-brain interaction disorders in accordance to wrong classification, and functional abdominal cramping pain is another classification, not accompanied by criteria by a Rome Foundation. And so, last two slides, with presenting functional types of pain with the irritable bowel syndrome, with its characteristics by in accordance to wrong criteria. It is often connecting with defecation and changes of stool characteristics. It's important because we can discuss it with the patient, and patient can give us very simple answers for a very simple question. And another one, functional abdominal cramping pain, is a brief, sudden, recurring cramping episodes lasting from seconds to minutes, not connecting with a stool change and not linked to defecation, and does not substantially limit daily activity comparing with irritable bowel syndrome, which in accordance to wrong criteria, as each gut-brain interaction disorders has 3 types of severity. And another form is a centrally mediated abdominal pain syndrome, or by the past definition, functional abdominal pain is another type of abdominal pain with a persistent and near constantly pain with a high intensity, not related to meals, defecation, and menstruation, and this is also functional disorder, often accompanied by stress and anxiety as soon as irritated by bowel syndrome. And so IBS and the centrally medicated abdominal pain cannot be explained by non-medical causes as an abdominal cramping pain. And so functional types of pain could be resolved by prescribing of antispasmodics and spasmolytics because of high burden of muscles spasms.